Hello and welcome to WorldCanvass from International Programs at the University of Iowa. I'm Joan Kerr, and we're broadcasting from the beautiful Senate Chamber of the Old Capitol Museum on the Central Campus this afternoon. This is part 2 of a 4-part series on the language of the brain. In the first part of this series, we focused on brain development, and in this segment, we'll talk about some neurological disorders that affect millions of Americans every year, and of course, many millions more around the world: epilepsy and stroke. My guests are Dr. Matthew Howard from the University of Iowa Department of Neurosurgery, just next to me here. Thanks, Matt.
Pleasure.
And at the far end, we have Tammy Lensing. She's a patient of Dr. Howard's and has graciously agreed to tell us a little bit about her experience with epilepsy. Thank you, Tammy, for coming. And in the middle here, we have Dr. Enrique Lara, who is going to talk with us this afternoon about stroke, and he's from the University of Iowa Department of Neurology. So thank you all for coming.
Pleasure. Thanks
for having you here. So Matt, I'd like to go to you first. And we've talked a little bit about brain development, but can you tell us from your point of view what causes neurological disorders to occur?
There's a wide range of disorders that can cause dysfunction in the nervous system. So the nervous system, we think about the brain, the spinal cord, and the peripheral nerves. And there are so many different things that can affect those structures that when you're a clinician, you think about it in a systematic way. And one way that you do that, particularly when you're first learning how to take care of patients who have neurologic disorders, is to put them in broad categories. So congenital, infectious, neoplastic, metabolic, demyelinating, traumatic, and you just go through this list, and you see a particular patient has a neurologic disorder, and you try to figure out what that etiology of those various groups it falls into, and then where the problem is in the neurologic system. But it's a very big aspect of medicine, neurologic disorders. And actually there are generally 2 types of specialists who take care of patients with neurologic problems. One is the neurologist, and one is the neurosurgeon. And Dr. Lara takes care of actually a lot more patients with neurologic disorders than I do as a neurosurgeon, because the neurosurgeons tend to take care of people who need surgical treatment for their neurological problem.
Well, one of the reasons we particularly wanted to have you on the program today was to talk about epilepsy, which I know is a huge factor in the lives of many, many people. I know there have been advances made over the years, but can you tell us a little bit about what epilepsy looks like, what it is as a disease? And
it is a very common problem. In fact, it might be about the most common in terms of the incidence of a person who's born and go through the course of their life. The odds of you having a neurologic disorder of some sort, probably epilepsy would be the most common when you consider febrile seizures, for example. So the incidence of febrile seizures, children who are about a year or so, is extremely high, like maybe 10% or so. Lots and lots of patients have those seizures. Those tend to be transient and temporary and don't cause any problems over the long run. But there are as many as 1% of Americans who have intractable seizures, meaning that they're past that stage where you have these transient problems when you're a neonate or a child, but have persistent seizures. And so epilepsy is very, very common. And there are different kinds. There are, for instance, complex partial seizures where the epilepsy originates in one localized area of the brain, and then there are generalized seizures, the kinds of things you see in movies that are very, very scary, where people are thrashing their limbs about. But the key there is to have a doctor assess what your neurologic, what type of epilepsy you have, put you on the appropriate medication, and most patients will have their epilepsy condition well-controlled medications, but a subset of those patients won't, and it's very, very important to find out whether there are other treatments that you might benefit from if you fall into that category.
Sure. Well, I was talking with Tammy before we began the program today, and I know that she did have a surgical intervention, and you were her surgeon. I wonder if you can tell us, before we hear Tammy's own story, what kind of surgery can help correct this part of the brain that causes seizures?
There are a variety of surgical procedures that can be performed to help patients who have failed medical management for their epilepsy. The most common type of operation is called a temporal resection, and that's what Tammy had. The way that we discuss this with patients and their patient's family and describe the whole sequence is that, again, there are a lot of patients with seizures. Most patients have their epilepsy well-controlled medication, but there's a certain percentage that don't. There are ways of determining where those seizures are coming from. And if we can determine that your seizures are coming from the temporal lobe, then there's a very good chance that we could eliminate those seizures with a surgical resection. So the seizure-free outcome in a perfect patient who has just the right combination of findings related to temporal lobe epilepsy is about 70 to 80%. So this is extremely high compared to, say, 5% or less for continued medical management, trying different medicines. So there's a sequence of steps that we go through. This is all in collaboration with our neurology colleagues who are experts in determining, first managing the seizures and hopefully controlling them with medicines, but if they're not controlled, they're the experts at figuring out where in the brain those seizures are coming from. And then as surgeons, we have quite refined techniques that are safe and effective to go in, identify with even finer resolution where the abnormal tissue is, remove it, and in most cases don't cause any problems, no neurologic deficits, and then you can get remarkable outcomes like Tammy.
Does the diseased tissue look different to the naked eye, to a surgeon's eye, than any other tissue?
Typically, when you look at it during surgery, it doesn't look any different than normal brain tissue. But when you look at it under the microscope, you can find abnormalities that are typical for patients who've had chronic seizures. Because chronic seizures, you have this storm of abnormal electrical activity that's happening. Very frequently, year after year, you'll see some structural changes in the brain.
Yeah. Well, I don't know if you'd like to add anything at this point, Dr. Lara, before we go to Tammy.
No, please go ahead.
Okay. So Tammy, thank you for coming this afternoon. I know it'll be really instructive for all of us to hear a little bit about what your history has been with epilepsy.
When I was 5 months old, so in January of 1978, I had a fall as a child where I hit my head and had a epidural hematoma bleed at that time, where they did a borehole procedure, and just before that surgery is when I had my very first seizure, which was what brought them to do the procedure at that time. And then I had no known seizures until Christmas Day of 1996, when I had a grand mal seizure when I was a sophomore in college and was home for Christmas vacation. And then had another grand mal seizure again in April of 1997, at which time I was started on medication at a low dose to see if that would control it. That was not able to. I was having 2 to 4 smaller seizures at that point in time, and over the years, they would ramp up where I would have more and more every year. They would increase my dosage of my medications. We trialed 5 different medications in multiple different combinations, and without success, to the point where before I came to have surgery, I was having 15 to 18 seizures per month. I had started to lose awareness periodically, where I didn't realize what was going on for several seconds, and then would jump back into what I was doing. And then also starting to lose urinary function without warning. I would have frequent auras where it would feel like somebody was watching me, or you get nauseated, just different symptoms where there were the smaller seizures occurring. And it was my neurologist where I was at that point that directed me here to the University of Iowa and to Dr. Howard, where we did a bunch of testing, and he determined that I was definitely fit for the surgery. We did surgery in May 23rd of 2006, and that morning was the day I had my last seizure. I've been seizure-free ever since, on a significantly smaller dosage, just a fraction of the medication that I was on prior to.
Wow.
I've been able to work as an inpatient physical therapist, which I wouldn't have been able to continue to do with the losing of awareness, because it would be unsafe for my patients to be working with them.
Wow. So that's the kind of success that you can have in the patient who fits those very close parameters and has a successful surgery.
We have, in patients who have this temporal lobe focus, the seizure-free outcomes are very, very high. Tammy's a particularly special case, though, in person, because Dr. Lara is, it's actually kind of a funny show about right now in a medical kind of way, is he's going to be talking about stroke. And almost a year ago, my mother was here from the East Coast and had a stroke. And Dr. Enrique Lara provided excellent care on the neurology side, but Tammy took care of my mother from the physical therapy side. So it was all that more special to know that, our team, and it's a total team effort. There's a lot on the surgical side, the medical side, big group of people who are highly trained. And to help people with epilepsy be able to not worry about suddenly losing awareness and then being able to pursue these things, and then to have this come back and help my mother, it was really special.
Yeah, that is great. One other question regarding all of these many, many seizures throughout your life. Did that affect your overall ability to think? I mean, when you were not having a seizure, had you suffered damage to the other parts of your brain? Do you know, Matt and Dr. Lara? Would the seizures have
Normally, patients with epilepsy had normal brain function in between the episodes.
Wow.
But occasionally they don't, and for a number of reasons, including the effects of medication, or if the seizures are frequent enough, they can leave some aftermath dysfunction in the brain where they don't completely go back to normal.
Yeah. Is there a connection between epilepsy and stroke, since we're headed in the direction
No,
of
really,
stroke
there are
anyway?
two different neurological disorders, but very, very common. Epilepsy is the poster child of episodic neurological disorder. That means that occurs at some point of time with potentially catastrophic consequences, but patients can go back to normal. But stroke is a one-time event. Is a sudden onset of a neurological dysfunction from vascular origin. That means from lack of blood supply to the brain, if it is an ischemic stroke, or due to a rupture of a blood vessel, if it is a hemorrhagic stroke.
And do we know what causes a stroke?
Well, there is a variety of things that can produce that clot that occludes the blood vessel and produces ischemic stroke. The list is very long, but they are dividing in three major categories. Either it's a problem with the arteries, like atherosclerosis is the most common thing in our society, or a problem with a clot form in the heart, or a problem with the blood itself, like the blood is clotting more rapidly or more intensely than it should.
So other than some of the things many of us are aware of now, like having somewhat clogged arteries, apart from that, is there any way to predict who will have a stroke or at what point they may have one?
Yeah, certainly, because a stroke is a random event, but in many ways is not. There are patients that are at risk of a stroke, at higher risk of a stroke than others. Of course, the most important risk factor is having had a stroke already. That is the biggest risk category. But we know that many of the conditions associated with sedentary lifestyle, as well as hypertension, diabetes, and obesity, and smoking, they're all risk factors that increase the risk of having a stroke.
So how many patients come to the University of Iowa? I'm not asking for a specific number, but I know that we're one of the sort of stroke net hospitals. Perhaps you can tell us what that means related to the NIH.
The number in the country is, we are now up to 800,000 strokes per year in the United States. And that is a number that, rather than get better, is actually increasing on a yearly basis, because as the population gets older, you're more likely to get a stroke during your lifetime. It's a consequence of actually aging of the population. So that means that every 40 seconds, someone is having a stroke. And every 4 minutes, someone dies from a stroke. It's the fourth cause of death in this country, but most importantly, it's the first cause of disability. So you're much more likely to survive a stroke and be disabled from it. So besides the obvious human suffering that goes with the stroke, there is a big cost for society, because those patients that have a stroke often are not able to go to their previous life and work. and then other people have to work for them from the physical therapy or occupational therapy or assistance service to get them back in track. So incredible cost for society.
What are the warning signs someone should be aware of?
Well, it's good that you asked this question because May is Stroke Awareness Month.
Good.
and it's important that, and we keep explaining to the population in general, but also those patients that are at higher risk of a stroke, the ones that we named before. It's important for patients and family members and caregivers to recognize the signs. So the key word is sudden. A stroke is something that one moment you don't have it, and the next moment it has occurred, for the most part. And sudden onset of a neurological deficit, that means a lack of function. So it can be sudden weakness, sudden numbness, sudden speech problems, sudden visual disturbance. The symptoms vary depending what side of or part of the brain is affected, but the key feature is sudden and lack of function. Also, an unusual headache could be a warning sign of a hemorrhagic stroke, the ones that Dr. Howard often takes, like an aneurysm rupture. But the ischemic strokes, for the most part, don't hurt, and that actually works against us because patients are much more likely to report to the emergency room if they hurt, like having a crossing chest pain and a heart attack, and they take longer when they have negative symptoms or lack of function. So it's very important to recognize those signs because the treatments for strokes are time dependent. So we have treatments for it, and we know that the outcome depends on how soon the treatment is applied. So to give you a number, every minute counts with a stroke, and the rate of neuronal or brain cell loss with a stroke is 1.9 million neurons per minute.
Wow.
So every minute counts.
So you told me that there was a phrase, time is brain.
Exactly, and we've been talking about time is brain for many years, but only until recently we can actually say how much time for how much brain. So every minute is 1.9 million neurons.
Right.
So of course we have a lot of neurons in the brain, like the previous speakers explained, but that explains why the outcome of the patients is going to be influenced by how soon the treatment is applied.
Now, I've heard that if someone can get to the hospital very, very quickly after what appears to be a stroke has occurred, there are things you can do right away that are likely to make the outcome better for that patient.
Exactly.
What kinds of interventions can you do at that point?
Well, the only treatment that has been proven to work is this clot-busting medicine called TPA, which fortunately can be given in most hospitals as long as they have a CAT scan. They have the medicine in storage, and they have the expertise to give it. Often the expertise is not available in most of the hospitals in small towns in Iowa, but fortunately we have a 24/7 service at the university and other stroke centers where the doctors of those small hospitals, they get in the phone with us, and sometimes through a telemedicine robot discuss the case. We can examine the patient as well and advise to give the treatment or not. So it's very important to report when someone is suspect of having a stroke, to show up in the closest emergency room that is stroke ready or stroke capable, and those hospitals are actually listed in the website of the Iowa Department of Public Health.
So just for anyone who may be listening to this discussion, if you suspect something may be happening to you, don't wait until Monday morning to call the doctor's office, but get yourself right to the emergency room.
The best thing you can do for the patient or your loved one is to call 911. This is a real emergency. It's a time-dependent one. We know that it's important not to get the patient in a private car for a number of reasons. One of them is the patient can deteriorate in the transport to the hospital, but also you are taking care faster when you arrive by ambulance than when you arrive by private car, and there's data to support that. And since time is of the essence, this is a reasonable use of the paramedic system.
Oh, so that's a very important tip. I hadn't heard that before. You're wiser to use an ambulance, much smarter to use an ambulance
Absolutely.
than to rely on yourself to get the ill person there. Can you tell me a little bit more about what it means for the University of Iowa hospitals to have a stroke net center related to this NIH?
So it's very important to advance new treatments in stroke, both for prevention of stroke, patients at risk, for treatment of the stroke itself. So we're looking for additional treatments in addition to this clot-busting medicine, or for recovery of the stroke. But doing stroke trials is very time-consuming for the doctors, which have a lot of other things and priorities, and the efficiency of doing clinical trials has been an issue for the National Institute of Health. So they came up last year with a new initiative, whether in order to be efficient in doing clinical trials in an appropriate way and fast, they are sponsoring a national network for stroke research, which has a coordinating center at the University of Cincinnati and 25 regional structures, and the University of Iowa was awarded one of these structures, so we are one of these regional coordinating centers that we worked with 12 hospitals in the state of Iowa that are cooperating with us for stroke research and being efficient in doing clinical trials. I think this is very important not only for the trials themselves, but also for the patients of Iowa, because a big issue with living in a rural state like Iowa is that it's very difficult for patients to participate in clinical trials because we are so far from the academic centers, and since this is a time-dependent problem, often patients in rural areas of the state cannot participate in clinical trials, which I think is unfair. So hopefully this new network is going to increase availability for patients to participate in trials, and we need more representation of rural populations in clinical trials so we know that the results apply to them as well.
Yeah, sure. Wow, well, we're coming to the end of this segment, but Dr. Howard, is there anything you would want to add to the discussion we've had so far?
Well, I guess the other thing I was thinking about in terms of the work that we're doing over there at the University Hospital, taking care of patients with epilepsy and stroke, is the training mission. The things that Enrique and I are doing, we were taught to do. We're trying to move the ball forward a little bit by making some advances, but the key is to have a well-trained cadre of doctors in the pipeline who are rigorously trained and do the right thing and are positioned to make new discoveries themselves. And the university has a key role in creating that kind of training opportunity.
Yeah. Well, I want to say thank you to all of you. Tammy Lansing, thank you so much for being here with us. And Dr. Enrique Lara, thank you. And Dr. Matt Howard, pleasure to have you all here. This has been the second part of a 4-part series on the language of the brain, and you're listening to WorldCanvass. I hope you can join us for the next program, in which we'll be talking about the aging mind and brain. WorldCanvass programming is available on YouTube, iTunes, UITV, and the International Program's website, which is international.uiowa.edu. So I'm Joan Kerr. Thank you very much for listening, and we'll see you next time. Good night.